morning, I'm Dr. Ben Dodd. Thanks for joining us at Bris Upper GI. Thanks for watching this video where today I'll talk about what is involved in the decision to proceed with hiatus hernia repair and anti-reflux surgery. Reflux disease, to the extent or severity where surgery becomes indicated, falls under three different patient groups. There's those patients that have severe reflux symptoms, and this is usually in the form of heartburn, burning behind the breastbone, or the sensation of gastric juices gushing up into the swallowing pipe or even the back of the throat and lungs, and this is often of a night time when patients are lying flat. And often patients with severe reflux disease get inflammation of the swallowing pipe muscle to the extent that food can stick on the way down. So those severe reflux symptoms, if they are refractory or resistant to medications and antacids, that's where it becomes a significant quality of life issue for patients, and the very safe modern version of the operation becomes a consideration. When patients have severe reflux disease, they often find that it's disruptive of their sleep. And when patients have reflux of this severity, disrupting their sleep, they're often made to be very miserable by it. And I think that's when they cross the threshold to needing to strongly consider what is, in this day and age, a very, very safe operation. The second category of patients are those with complex reflux, where they get Barrett's esophagus, which is a precancerous change in the lining of the swallowing pipe tube. And if that is high-risk Barrett's, that is long segment with precancerous change, these patients have often come from a gastroenterologist where this precancerous Barrett's has been burnt with radio frequency ablation and various other treatments. And in these patients, not so much because of their symptoms, but because we're trying to reduce the drive for them to get esophageal cancer, we consider the surgery. And esophageal cancer is still very hard to cure people of, and hence our reasoning for putting you through this safe anti-reflux procedure. The third category of patients strangely often do not have significant reflux disease, but they come from usually respiratory doctors with severe adult onset lung diseases, and these can be in the form of asthma, recurrent lung infections and bronchiectasis, or idiopathic pulmonary fibrosis, meaning scarring developing in the lungs as a consequence of chronic, what is called laryngopulmonary reflux, or LPR, where the stomach juices are regurgitating back up through the swallowing pipe of a night time and thereafter trickling over into the airways and causing a chronic injury to the lungs. And these patients, once again, they're often not terribly symptomatic, but we're doing the operation to reduce the risk of them having irreversible lung damage and the potential for a need for lung transplant. So three categories of patients: severe reflux symptoms, high-risk precancerous change, or severe reflux-related lung diseases. So those are three sort of main indications for anti-reflux surgery. Patients can have reflux disease of all forms in the presence of hiatus hernia, or some patients just have a great weakness of the normal valve that sits between the swallowing pipe muscle or swallowing pipe tube and the stomach. And in some patients, for unknown reasons, this valve or lower esophageal sphincter, LOS, is weak and lacks the normal tone that it should to stop stomach juices refluxing into the esophagus. Furthermore, patients can, over time, when they've had a hiatus hernia for a long period of time, the natural history, dependent on various lifestyle and patient factors, is that the small hiatus hernias can progress to what is called a giant hiatus hernia. This is defined by patients having at least a third of the stomach in the chest, or more than 5 centimetres in head to toe body length of defining the length of the hernia. In the extreme form, these giant hiatus hernias can actually include the whole stomach, and so the patients end up with what is called an intrathoracic stomach, or the whole stomach is up in the chest. And these patients often do not have so much in the way of reflux, but develop different symptoms, what the doctors call obstructive symptoms, where the stomach kinks in the chest, and that can give patients difficulty eating, where they feel full prematurely, or they get chest pain when eating, or sometimes even vomit food back up. Patients with giant hiatus hernia can also quite commonly have a very noticeable decline in their exercise tolerance. And this is because the bulk of the stomach sitting up inside the chest is very unnatural for that to be there, and it pushes on the heart and lungs and impairs the function of both these organ systems, and the patient's exercise tolerance reduces. Patients with a giant hiatus hernia, where the stomach is up into the chest and being squeezed as it moves up and down through the normally esophageal hiatus, meaning the aperture in the diaphragm sheet between the chest and abdominal cavities. As the stomach moves up and down through this hiatus, it can develop little ulcers in the internal surface of the stomach. And this is quite a common way that these patients present, where they have a chronic loss of iron or chronic loss of blood cells, and therefore end up iron deficient. And often these patients have had an iron infusion. In the extreme case for giant hiatus hernia, patients can present with the stomach, as it becomes abnormally situated in the chest, becomes very abnormally mobile and can twist and kink on its blood supply. And this is a surgical emergency called a gastric volvulus, and patients with this sort of condition need very urgent surgery, or part of the stomach can die off in the chest. And so we never want that to happen. So if patients have a giant hiatus hernia and it's quite symptomatic, and if they're fit for an operation to have it fixed, which is about an hour and a half duration, we tend to suggest that they have it fixed. So we've talked about giant hiatus hernias and hiatus hernias. Now I just wish to talk about the operation to fix these. Now, whilst the magnitude of the hiatus hernia is different between these patients, the way we dissect it all out and put it all back together, that is laparoscopic hiatus hernia repair and fundoplication, is actually done very similarly. For the giant hiatus hernias, the procedure takes significantly longer and there's more dissection and I suppose a tiny bit more risk involved, but actually the procedures are always extremely safe, with roughly half a teaspoon of blood loss, minimal pain for the patient. But what we're trying to do is basically dissect out and mobilise the junction of the swallowing pipe and stomach, whether that is in the chest or in the abdomen, and then mobilise the swallowing pipe from its attachments in the chest, bring the stomach back into the abdomen with no tension. Once that part of the operation is done, the hiatus hernia, or the aperture of the hiatus where the esophagus normally goes through, is shaped like a little window, and in a giant hiatus hernia it tends to be big, but in all these cases we tend to bring that back together gently with a few sutures, never with any tension. And then once that's done, the floppy redundant part of the stomach gets wrapped around the back of the esophagus in the abdomen, and that does two things. That compresses the swallowing pipe in the abdomen very gently, but basically creates a new anti-reflux valve, and it also serves to anchor the stomach in the abdomen to stop it trying to ascend back up into the chest. So these operations in 2024 are extremely safe. They're laparoscopic every time. They take between 1 and 2 hours. Patients should never ever have an open operation or their spleen removed or a hole in their esophagus. So the surgery is very, very refined and safe from what it was even just 20 years ago. And furthermore, the horrible side effects that some patients had to endure for hiatus hernia and fundoplication surgery in years gone by just should not happen anymore, because the operation used to involve a full 360-degree wrap and a lot of tension in that. And because of the terrible side effects patients got of inability to eat solids, or of terrible bloating and wind from the back passage, that evolved to become a floppy loose 360, but now we do a more floppy posterior 270-degree fundoplication, and that gives the right balance of very good reflux control whilst keeping the side effects to a minimum. And I tell patients that they're probably going to feel a little bit bloated and probably going to notice a little bit of wind from the back passage, but usually for the vast majority of patients those side effects are temporary. There is a post-op diet consistency limitation, but that resolves over between 2 and 4 weeks post-operatively, and patients can then eat whatever they want to thereafter. I will see you in due course. Hopefully this has been informative and I can answer any more questions you have when I meet you in person. Thank you.